Polytrauma is a systems problem. Here's the protocol. Most veterans and TBI patients are treated like a collection of separate symptoms. Depression over here, fatigue over there, cognitive fog somewhere else. That approach is incomplete. Polytrauma syndrome is a systems-level failure involving the brain, hormones, metabolism, and energy production. Until you treat it that way, outcomes stay poor and suicide risk stays high. TBI and PTSD commonly coexist, especially in military and contact sport populations. What many clinicians still miss is the high rate of hypothalamic pituitary dysfunction after injury. Literature shows hypopituitarism in 20–50% of these patients, depending on severity and when you look. Common deficiencies include testosterone and luteinizing hormone, growth hormone, oxytocin, and dysregulated vitamin D metabolism. These aren't minor laboratory findings. They drive persistent depression, anxiety, fatigue, cognitive impairment, loss of motivation, and elevated suicide risk. Conventional care rarely screens for them systematically and almost never treats them as part of a coordinated protocol. I am Dr. K. Paul Stoller, Lifetime Fellow of the American College of Hyperbaric Medicine, and I have proposed a multimodal protocol that targets 3 interconnected domains: neuroendocrine, metabolic, and cerebral energy failure. It is deliberately systems biology-oriented rather than symptom chasing. The goal is not another isolated intervention. The goal is to restore the underlying physiology that keeps these patients stuck. Start with a proper workup, not the usual truncated panel. Total and free testosterone, DHT, estradiol, LH, 25-hydroxyvitamin, D, HbA1c, standard metabolic and inflammatory markers. Post-TBI hypopituitarism is still underdiagnosed. You cannot optimize what you do not measure. For secondary hypogonadism, enclomiphene can raise endogenous LH and testosterone while preserving spermatogenesis. Monitor DHT and estradiol closely. Anastrozole is available when aromatization becomes excessive. Intranasal oxytocin has evidence for reducing amygdala hyperactivity, modulating fear responses, and supporting trauma processing. It is used as an adjunct in appropriate patients, with the usual exclusions: pregnancy, active opioid dependence. When insulin resistance or elevated HbA1c is present, berberine offers AMPK activation and mTOR effects comparable to metformin, often with better gastrointestinal tolerance. Low-pressure hyperbaric oxygen is the neuroenergetic piece. Protocols in the 1.3–1.5 ATA range have shown improvements in cerebral blood flow, cognitive performance, and post-concussive symptoms in chronic TBI. The specific parameters I propose: 1.5 ATA, 60 minutes, once daily, 2 cycles of 40 sessions. Before initiating HBOT, consider screening for neuroinfectious contributors, such as Borrelia. These organisms are microaerophilic. Sudden high oxygen tension can provoke inflammatory reactions that complicate the response. After HBOT-driven neuroplastic changes, modafinil can support attention, executive function, and wakefulness without the addictive liability of stimulants. It helps meet the increased metabolic demand of recovering cortical networks. This is not a claim of definitive cure. It is a biologically coherent framework that refuses to treat the brain, the endocrine system, and cellular energy production as separate silos. Standard care still does exactly that, and the morbidity and mortality numbers show the cost. Polytrauma is a multi-system injury. Symptom management alone is not enough. Hormonal optimization, metabolic support, and targeted hyperbaric oxygen address the actual physiology that keeps these patients disabled. Given the ongoing burden of TBI-related disability and suicide, structured exploration of this kind of multimodal approach is both clinically and ethically justified. The full paper is available in Primera Scientific Surgical Research and Practice, Volume 7, Issue 1. Link in the description if you want the references and detailed rationale.